All right, everybody. So today, back on the podcast, we have Dr. Ralph Esposito. How you doing, man?
Thanks so much for having me, Dave. I appreciate it. It's fun to get at this again.
Yeah. I think this is either your third or fourth time because I was going back looking through some old ones, and you were actually one of the first guests. So that was like
Mhm.
2018 or so, which is weird. It just really never feels like it's that long, but I guess we've actually been in touch for a little while there. So always great to have you back on.
Yeah, thanks so much. It's been, I think, definitely the third.
Yeah. Yeah, it's been at least a few times. So welcome back. I know you're very busy, and yeah, right now you told me everything's kind of remote, right? So you have a lot of telemed calls going on all the time. So it's always great to get you here. There was a few topics specifically that I wanted to dive into. I know you deal with a lot of men who are TRT. You talk a lot about like men's health. So I guess if somebody hasn't seen, because it's been at least a year since we've had you on, so maybe
Mhm.
just a brief primer on your background here.
Sure. So I'm a naturopathic physician and licensed acupuncturist. I did my undergraduate training at NYU in nutrition, then went on, completed my doctorate in naturopathic medicine at the university, a little bit at Bastyr University, and then went over here in Connecticut on the University of Bridgeport. Also completed my master's there in acupuncture. So I practice acupuncture in traditional Chinese medicine. Then did postdoctoral training at NYU urology with my mentor Gio Espinoza. It was really taught me a lot, and I've learned an immense amount from him and the other incredible doctors there at NYU. And then after just finished up, went into private practice and now work as an associate in a private practice that's mostly remote.
So, and I actually, because I did see that you're licensed in acupuncture, and one of the first things when I first had you on, we talked about, there's allopathic, naturopathic medicine, and like there's debates and all of that. And I guess generally speaking, like even like within the fitness stuff, I see a lot of like evidence based. Like I really try to stick to like evidence based stuff, but there's also I think some people think evidence based means something different than it does, right? And they think it means like only if you have long longitudinal studies, and that's really not the only thing that we look at when we look at evidence. I know acupuncture and some Western medicine and everything, and versus Eastern medicine is. I guess there's still controversy on it. So I'd actually like to hear your perspective on that because I know you work with some people who I hold in high regard. So maybe you can just dive into why there's still controversy over that and what you've seen with traditional medicine versus maybe like acupuncture.
Yeah, I think over the years, when I first started, even before I started practicing, the thought was there's no evidence behind integrative or holistic or non-conventional medicine.
Mhm.
It either must be a prescription or something approved by the FDA or not. Um, and that's really what divided the line between evidence-based or not. When some people think, is it evidence-based? They think, well, is it approved by some larger corporation or organization like the FDA or the NIH or uh, even insurance companies? And we're starting to learn that that's not actually, it's not an actual solid line, right? It's not
Mhm.
black and white. And what we're learning is that a lot of stuff can be considered evidence-based, even in conventional medicine, but not be uh, convincing enough. Uh, or there are things that are not evidence-based in conventional medicine that still are helpful and useful, right?
Mhm.
So things like, you know, Clomid, clomiphene, which is a drug used for fertility in women,
Mhm.
is used now in men, and there's a lot of research on it, but it's
Yeah.
used off-label for
Right.
men. So it gets very gray in that area. And then the way that I look at it is not necessarily as something evidence-based, because something can be based on evidence, and you can have like a study to show anything works or doesn't work. But it's more about evidence led. Are you treating and are you practicing medicine in a way that is led by the evidence that we actually have? And a good analogy of this is, we didn't need a double blind randomized placebo controlled trial to prove that brushing your teeth prevents cavities, right?
Mhm.
And in your field, you get this. Like
Right. Right.
I don't need another study to say, this type of brushing, maybe it might be electric versus not, right? Like types of fluoride, et cetera. But we don't need that study because we know that brushing your teeth prevents decay in cavities and et cetera. And I think that's a similar approach that I take. I don't need to wait 15 to 20 years to wait for something to be proven. And one of my early professors at NYU for Gen Chem, he said, don't you ever come to me and say something is proven. Like this is even in Gen Chem, like basic chemistry that's been around for, almost 100,000 years. Actually, no, I mean, it's derived from that, but it's very well established. Even then, he was like, don't tell me something is proven because nothing that we do is proven. It's only just experiments and theories that are repeated over and over.
Right.
And that's essentially what we're trying to do. In my approach to medicine is, look, I see some evidence suggesting that this works. Biochemistry, physiologically, nutritionally, all the above makes sense. Anatomically, all this stuff makes sense. Let's see if we can repeat it with multiple different studies to lead me in the right direction to actually help somebody now.
Right.
And we're learning that even so with, if you look at cigarettes, well, when cigarettes were first being, not first being used, they're still used now, but when they were very popular and people just thought that they were harmless, there was no studies then, but I bet you there are people saying this stuff is probably not good for you because you're inhaling a smoke that's going into your lungs. And then we started learning, well, yeah, actually that stuff causes cancer. So that's how I try to create this analogy of people understanding, well, you don't necessarily need the holy grail of studies to prove something is effective, and you'll never prove it's effective. You'll never ever be able to prove something is 100% effective, but you can assume with strong confidence that something is going to be helpful for X individual or X individuals.
Yeah, I mean, there's, Chromate's a good example. There's a lot of examples of things that are used off-label that are shown to be helpful. And just because, like on the other side of it, just because the FDA has approved it doesn't mean, I know there was actually a controversy somewhat recently, right, with the FDA approving an Alzheimer's drug, I believe.
Yes, aducanumab.
Yeah, and my general thought as a principle on this matter is like, if we have clear evidence that something doesn't work, study after study shows like it just doesn't work. Again, not saying you can prove it doesn't, but I think you can get to a point where like, all right, this is probably maybe not helping, but there's a huge category of things that we just don't know enough yet. So if you have, and again, there's obviously a door here for a charlatan to come through and say, well, yeah, exactly. We haven't proven that my mud mask cleans out your colon or some craziness, right? Obviously. Right. So you have to be able to parse it out, which can be very difficult. I'm just saying I'm open to things. There's a lot of people out there who struggle with health issues and struggle with issues that we don't have perfect answers for. And if there are things that a number of doctors and other people are trying that they feel is working for them, I'm open to it at the very least. So,
yeah. And I think that's what people want to look for. And I know your audience is probably, doing this themselves. Is like, what do I look for in a doctor? And you want to look for somebody who's not so dogmatic and stuck in this confined structure of guidelines or not. I think guidelines are helpful. I think guidelines can tell us when you're really out of your lane and when you're not. But I think it's important to look for somebody who thinks differently, but not too excessive, not too far either way, that you start questioning, well, is this actually right? Because remember, conspiracies and controversies and anything that is so different and so extreme actually sounds very appealing to people, right? And it's very easy for people to catch that and say, oh, well, that acupuncturist said that he's going to decrease the size of my tumor. Have I seen acupuncture decrease size of tumors? Yes, I have, but I'm not going to make that claim. I'm not going to, and I can't even say acupuncture decreased the size of the tumor. I can say that there are individuals who had acupuncture and over time, the size of a benign tumor decreased in size. But I can't say that that's actually contributing to that. But what appeals to people is for them to hear somebody like me with credentials, yeah, do this, and you're going to decrease the
Right.
size of your whatever, your tumor, or, help your hair grow back where it hasn't grown in, 20 years, right?
Right.
Those are the extremes that appeal to people. And people like controversy, people like extremes. And I think the first thing that you can ask is like, why isn't or why aren't 20 other doctors saying the same thing that I know are credible because are tried and true in what they do? I think that's one of the more important things, because I do see a lot of people who MD, ND, DO, dentists, pretty much, physical therapists, and they'll say stuff. And I'm like, that's just a complete crock. Like
Yeah.
and it's not like, oh, I'm open. I am very open-minded and I can be open to thinking of a different approach. But there are just things that I'm like, there's no way that
Yeah.
this specific thing is going to treat, your hair loss. It's like,
Right. Right.
it's not going to happen.
Yeah, it's tough. I mean, it really is tough because I've seen, like I've had family members who have had like chronic autoimmune issues or issues where it's like we just don't have great answers. And I can fully understand how somebody in that dealing with chronic pain, dealing with no answers, spending thousands of dollars goes down a path looking for answers. And it's hard, and most people don't even, I mean, even for us, I think probably it's hard to parse some things out, but somebody who has no training, I mean, it's very difficult. So I can certainly feel for that. So I have some general questions, some stuff on longevity, some stuff on like male health. One that I don't think we'll probably have a long conversation on, but I related to longevity. I've heard more and more about rapamycin. And I'm just curious if maybe you could just briefly give like a primer on, I guess, what the current evidence seems to suggest it might be helpful for. I've seen it in a few, like there was one study on mice with dilated cardiomyopathy that it just seemed to like almost completely reverse it. I think there's another study on dogs with cardiomyopathy that it improved, but not as much. And then I don't think any on humans. But I know some people talk about it as far as like helping longevity. And obviously it's not prescribed for that, but just maybe if you could just give a little info.
Yeah. So rapamycin is an immunosuppressive drug. Used most of the time for transplants and individuals who get organ transplants. And over the past few decades, there's been an immense amount of research on it where it's been shown to improve lifespan in multiple different animals, from worms to mice to dogs, as you mentioned, to pretty much every single animal kingdom. And although the mechanisms are not entirely played out because we're still learning, it's likely through its inhibition of mTOR. So mTOR, it gets a lot of attention because it's what a lot of people use fasting to try to manipulate. So fasting, the act of fasting will in a way inhibit mTOR. And that's because mTOR is usually a nutrient sensing receptor or agent. So essentially, anytime that there is a low amount of calories, specifically certain amino acids like leucine, that mTOR will slow down. But that's not the only way to impact mTOR. It's suspected that even metformin can help inhibit mTOR through its mechanism of AMPK, which is still arguable as to whether it's helpful in individuals who are not diabetic. So what can happen is that when you inhibit mTOR, what it's doing is slows down the aging process by working on different mechanisms. One of them is improving autophagy, which is another mechanism aimed for in people who like to fast. So it's not a drug that's used for longevity. I'm not recommending anybody go ahead and ask their doctor for rapamycin. Even metformin, I don't know if I'd be very bullish on recommending that for longevity. But it's interesting, and these are one of the areas where we are trying to investigate: is this something that can be helpful for with low risk, right? Because not everything has no risk, but do the benefits highly outweigh the risks in this specific agent, rapamycin? And similarly to how, in the past they've used different medications at varied doses for different benefits, like naltrexone, low dose naltrexone
Yeah,
actually
that's what
can
I
be
was
quite
thinking of.
helpful.
Yeah.
Yeah, I think that's kind of the area that Rapa is working through, but a lot more investigation is needed. But experts in this field are very confident that it's quite helpful for longevity. But I still think I hate to use this analogy, but the jury's still out on that. I think it's leaning towards it being a helpful drug for longevity, but I think we need some human trials.
Is it in any way, because like when we talk about mTOR, a lot of people listening will think like, oh, we have to stimulate mTOR for muscle growth and whatnot. And to some degree, the things that we look for maybe like maximum performance, I know are obviously probably not the best for longevity if you're talking about the extreme ends. To some degree, we do talk about these stressors in life, like working out, like extreme heat, things like that, that even though chronic amounts of it would not be great, it seems to be this hormetic response to, like individual smaller doses of it. Could that be analogous to what you see with mTOR, where like, the mTOR response we get from working out or higher protein intakes is not necessarily going to be problematic from a longevity standpoint versus the longer term suppression with rapamycin, if that makes sense?
Yeah, I absolutely agree. And now remember, I think a lot of people misunderstand, or I should rather say, I think a lot of people understand physiology more than a lot of people think they understand physiology more than they actually understand physiology. And very rarely in biology is one system completely turned off or completely turned on, right? So I hear people always talk about you have to turn off your sympathetic nervous system and up your parasympathetic. If you did, you would die, right? Because you would not have a heartbeat. You need some type of sympathetic response. So it's all relative. So, and that applies to even hormones as well, and receptors like mTOR. You have to keep insulin as off, like insulin production off. It'll never be off. It'll never be completely zero. It can be suppressed over a long times of complete fasting, right? But at some point, the body needs to get glucose into the cell. So there's always a very low level circulating in the blood, but might not be detectable. And the same thing comes with mTOR. I think we can't lose the benefits of the foundations of health when it comes to sleep, nutrition, and exercise. And exercise, if you told me exercise is bad because it stimulates mTOR, I would say you're probably out of your mind, right? Because anybody who says exercise is bad for you clearly has not looked at the evidence of muscle mass, cardiorespiratory fitness, your ability to utilize fuel as energy, like basal metabolic testing, and that strong correlation with reduced cardiovascular risk and overall mortality. And those things, being very fit, right, having a high cardiorespiratory fitness, having a improved muscle mass, require you to be active and require mTOR to be active too, because otherwise you won't be able to synthesize protein and muscle. So I think it's very clear that it's a Goldilocks type of rule rather than an all or nothing. So it's can we get intermittent suppression of mTOR or intermittent stimulation of mTOR at high levels and low levels, not complete on or off, so that our body can maintain this homeostasis. And actually, there are benefits of muscle protein synthesis and there are benefits of fasting. But that doesn't mean you have to do all of them. And I also think that most people think fasting is like 3 days. Like I have to fast 3 days, otherwise I don't get a benefit. That might not be true. It might be just 24 hours. It might be enough to help regenerate and stimulate autophagy. Research suggests that it might be. So you don't really need to go all out, and more is not always better.
Yeah, the longevity research, as well as, just fasting, all that is very interesting to me. And I know right now it's not totally clear. It'll be interesting to see if I don't know, next couple of decades, maybe like what comes out. I personally have done intermittent fasting like before, like I feel like it's, you know, it kind of goes in waves and people find it like more popular, but even since 2011, I've been doing it just like kind of the standard 16/8.
Mhm.
Every week I do one 24-hour fast. So I finish my last meal on
Cool.
Sunday, and then on Monday night I eat. So a lot of times when I say 24-hour fast, people think I don't eat for a whole day, but that would really be like 36 hours, right? So,
Right.
um, and I do that every week, and it's not. It would be great if it's giving me nice benefits. It's actually partly convenience. My Mondays are very busy, so it's easy for me to do
Mhm.
it. I have some GI issues, so it's kind of nice to just not eat for a day.
Right.
But it would be great if I found out that, you know, there are some long lasting benefits. I mean, you would know even better than I would. I've seen the research. I just don't know if there's anything like super conclusive, like long term.
Yeah, I think where a lot of the benefit, where a lot of the research is suggesting is um, on autoimmune conditions.
Mm-hmm.
It can be very helpful for perhaps Alzheimer's or dementia prevention can be helpful for as well. I think it hits almost every body system when it comes to that. IBS/IBD can
Yeah.
also be helpful for that for obvious reasons because you're letting the
Right.
gut rest. But this is the issue. Like the research wants to apply it to everything, and then I think like what are the big hitters that fasting can be helpful for? And usually, what I see it is for diabetes
Mm-hmm.
or insulin resistance, autoimmune conditions, and GI issues. That's
Yeah.
where I would say the most benefit is pulled from.
At the very least, it makes me feel better. I don't know if it's resulting in a long term lowering of inflammation. But sometimes I do think, like, you know, how much worse could I be if I didn't have all of these dietary things in place and my sleep hygiene and all that? Like, I'd like to think that it's, you know, each little thing is a little block that adds up and at least helps me.
It does, and I think that's where a lot of people are misunderstand how integrative medicine works. They think it's analogous to take a pill and it'll treat this, right? Take a pill, take this birth control for your PMS, or
Right.
take this, uh, migraine medicine for your migraines, right? So, but that's not how it works. The way that it works is we have to reduce the amount of stress and the pressure on the body to ease off on the systems that allow the body to actually recover.
Right.
So we see this often in individuals who are sleep deprived, where we we or have issues sleeping, I should say, is that when we reduce a lot of the other stressors in their life, like their stress, their training, or their diet, they're able to function at a better when they have less quality sleep. Now, I'm not saying less quality sleep is good for you,
Mm-hmm.
but where the body senses stress in multiple different ways, from nutrition, like lack of calories, from injury, from sleep deprivation, from environmental stressors like toxins, from social stressors, from emotional stressors. And our goal is to actually reduce the inputs of all these things to allow the body to handle how much these stressors it can do. And then once we exceed that threshold, that is when disease occurs.
Yeah.
So the goal is not necessarily, fasting is going to cure whatever, but will fasting help me recover better for X things, or will it help me reduce the amount of stress is in my life for, sugar sweetened foods? Like, yeah, it probably will. And that's going to reduce the load, but it's not going to, resolve the other issues that are coming along. And that's where it's really important to pay attention.
Right. And so, you know, we've talked about longevity, we talked about diabetes. So tangentially, I wanted to get your opinion actually a lot on continuous glucose monitoring,
Mhm.
because I actually had somebody like a company send me one, and I feel bad. It's been like 2 months. I've just been very busy. I haven't even gotten to use it, but it's a month's worth, and I've never. I mean, I've looked into it, but not a lot. You know, I've certainly heard people talk about it. It's not an area I've never had an issue. You know, my HbA1c, my fasting glucose, they've always been fine. When I've had like I've done keto a few times and bought the like Keto Mojo monitor, and I've never really had any issues with it. But I still am a very curious person, so I hope to start it within the next couple of weeks. And maybe you could just touch on where we think it could be useful, most useful. I obviously diabetics, but you know, for the, like the lay person, what can we get valuable data from that?
If you are a person who, well, I think I consider myself somebody who eats very well. I don't really consume sweets. I don't really have desserts. I drink very little, if ever, by choice. And the CGM for me, even then, was very helpful. So just because you eat well doesn't necessarily mean you can predict what a food would do to your body. So I think everybody can benefit at least from a month's worth of CGM. And the reason why is because you'll be able to see not only how does food impact your blood sugar, but how do other things like sleep quality or sleep deprivation or exercise or lack of exercise, walking versus running versus sprinting versus strength training, like all of these things will impact your blood sugar. But I think at the most basic level, a CGM will allow you to identify which foods spike my blood sugar and what can I do to regulate that or correct that. And blood sugar is a problem, but blood sugar is not really my target. And that sounds very contradictory. But what do you mean, Ralph? Like blood sugar is really important. Like, yes, it is. But that blood sugar is a proxy for insulin. So I have to assume, and most of the time physiology would agree, that when blood sugar is high, insulin is high in a non-diabetic individual. Now, if you're type 1 diabetic or insulin-dependent diabetic, your blood sugar will be elevated and you won't have insulin.
Right.
But insulin is the problem. Insulin is what drives the sugar into your cells. Insulin is what prevents lipolysis and for you to burn, I hate the term, but burn fat. Insulin is pro-inflammatory. Insulin stimulates pro-inflammatory enzymes. Insulin is the problem. That's the actual issue. Blood sugar becomes a problem over long periods of time when it's uncontrolled. And that's diabetes, right? And that's not what I'm talking about here. I assume most of the people who are using CGM now, who are like not diabetic, are using it to see what is it doing to their blood sugar. So that's what you have to look into. And it allows you to identify what foods agree with you, what foods are problematic, even foods that you didn't even think would be problematic might be. Like, you know, for me, sweet potatoes, a big problem, right? Yeah, a big problem. Actually, just as bad as sweet potatoes. Regular potatoes. So no different for me in terms of blood sugar response. Other fruits like apples, very bad for me. Like spike my blood sugar.
And is that alone or within a meal?
I always do, whenever I'm doing a new food, I always do it alone.
Which makes sense. Like, I would just wonder, are these foods, you know, just for people listening, generally speaking, it seems if you eat it with protein, if you eat it with fiber, it's going to lower the response. So are you still eating those foods, but just with other things?
Yeah. Whenever I want to figure out what a food is doing to my blood sugar, I always do it alone and most of the time in the morning. So really, there's been nothing in my body besides this food. Or if I do it in the afternoon, it's been about 4 hours since I last ate, my blood sugar is stable. So it's usually, I average around like 80 to 85. Standard deviation, usually less than 10. So if I'm level, then I'll introduce the food and see what it does to my blood sugar. And that will tell you, you know, is this food alone problematic for me? Now, you're right. You can dampen the glycemic load or the glycemic response to a food by introducing either protein or fat or fiber. But basic nutrition tells you that, like, you should have, you know, fats with your foods and protein with your meals because it stabilizes your blood sugar. But now you can actually see it. And now you can actually see if it does that for you. I haven't done like apples with like almond butter, but
Mhm.
maybe that would blunt the response. I'm sure it would relative to
Right.
just an apple, but I know enough that that apple is going to be problematic for me, and I just avoid it as much as possible if I can. Also, not a fan of apples, so
Yeah. I would
um,
just wonder,
but
like what's a good food, a carb source for you, for example?
quinoa does
So
not spike my blood sugar.
it would just be interesting to me if you took 50 grams of carbs from sweet potatoes, 50 grams of carbs from quinoa, whatever your amount. Obviously, you just said you know the response. I would be very curious to see if you had that same 50 grams with whatever 5 ounces of like a somewhat lean ground beef,
Hmm.
and just to see like did it actually completely even it out? Where in that case you could almost make the argument you don't have to think about it if you're eating it within meals, or was it still relatively still higher with the sweet potatoes? I don't
Hmm.
know if you know the answer to that.
Yeah, uh, it depends on how insulin sensitive somebody is. So these foods are less likely to impact me because I have a relatively higher percent of muscle mass,
Mm,
which is really your best way of utilizing sugar. But yes, if you corrected for total carbohydrate grams, um, in me adding it with a protein. Now again, we're thinking, sweet potato with ground beef. Is it a 90-10, or is it like
right.
an 80-20? Right? The more fat, the more blunted it's going to be. So it's so, again, this is the art of the nutritional sciences. This is why nutrition is so controversial. It's probably more controversial than politics. So it's everybody has an opinion
Mm,
because everybody eats and
yeah.
everybody thinks that they know what's going on. Same way as like everybody votes and everybody works in the government. That means you know everything that's going on. It's like,
Right.
no, I don't. I'm sorry, and I'm not going to try to. And I think that's the same way for nutrition. So that's where even even myself, I am humbled many times by my patients where I say, they're like, I'm eating really well. I'm eating good foods and foods that I told them to eat. Like
Hmm.
you can have quinoa and you can have berries and you can have, half a banana on occasion. And then I realized I'm like, yeah, this is not good for them. And even myself, I'm very knowledgeable. I still need to figure out what works for that person. Now, could I figure that out over 3 months, 6 months of visits, consultations, lab work, progress? Yeah, I could probably tell you. You know what? You've been eating quinoa for dinner 3 times a week. It's probably not good for you. Let's see if we cut that out. What happens? And most of the time, when we make those little tiny changes, people respond. Um,
Based on
and
what? Like
that's,
you're saying, if you didn't have the CGM, you'd still maybe be able to figure it out. Would that just be based on other blood work, or?
yeah. So I would look at things like a glycomark. I would look at things like a hemoglobin A1C, fasting insulin, blood glucose, looking at their lipids, right? All of these things, and even things like their body fat, their weight.
Yeah.
Are they getting stronger? Um, all of these things kind of come into play. But with a CGM, it allows you to do it quicker, and you can identify that
Right.
sooner and help people, more conveniently.
Yeah, it's very, as somebody who has twice done a extremely strict elimination diet, starting with like almost nothing, adding foods and trying to determine based on symptoms and symptoms can fluctuate. I would love if there was like a continuous like CRP monitor or inflammation monitor, something like
Yeah.
equivalent, because it can be extremely difficult to determine what this one food does, and maybe it's the next day that you feel off. And so I think for people who, if you believe that the glucose fluctuations are very important, then yeah, I can't think of anything better than a CGM to kind of determine that. Do you have a level where, like, some people would argue, well, as long as it's under 100 it's fine, or maybe if you're eating it's under like 130? Do you have a level where you're like, this is now what I would consider problematic?
For average blood glucose,
Yeah, like a response after introducing the food.
postprandial. So
Yes.
after having the food. Okay. Anything above 140 is problematic.
Okay.
So if something spikes your blood sugar above 140, it's creating a hyperinsulinemic response, that means it's probably not the best for you. But also what you need to consider is how quickly does it drop?
Mhm.
How quickly does it go to normal? There are a lot of individuals who, even myself, if I haven't eaten in almost 6 hours, right? So if I went and had a apple or a banana, my blood sugar would go over 140,
Wow.
probably over 150. I just took out my CGM, but once I get one back on, I'll let you know what happens. I'll do
Yeah.
this for you. My blood sugar will go up above 140. I actually did a post on this, which talks about how apple cider vinegar can blunt the blood sugar response, but we can talk about that in a second. But the speed at which, or the rate at which blood sugar drops is actually a better indicator of insulin sensitivity than what your absolute peak is.
Mhm.
So that's basically like an oral glucose tolerance test.
Right.
When pregnant women take a glucose tolerance test, they're doing a pure sugar, and they see that their blood sugar spike, after 2 hours, and anything above 200 is problematic. That means that it was definitely above 200 prior to that 2 hour response, right? So it
Right.
must have been at like 300 or 250 or whatever it is. But if it does not come down below 200 after 2 hours, that means you're not utilizing that sugar as energy. And
Yeah.
that's insulin resistance. So what's more important is how quickly do you respond and get your blood sugar back to normal.
Interesting.
Not essentially what is the max level.
Right. Yeah, I'm very interested to kind of play around with it. And just two like quick stories of mine, like playing around with the like the ketone and glucose monitor. So years back, so my aunt is a type 1 diabetic, and at Thanksgiving we were just curious. And this is why I'm interested to see the responses with combinations versus solo, because I'm like, I don't know, 23 or something at the time, and just total eating everything on Thanksgiving. And we I mean, I don't know, 5, 6, 7,000 calories, and we tested my blood glucose, and it was like 130. Now again, you're talking about a quite active 23-year-old who, and there's also plenty of protein and fats and things like that. Maybe last year when I was like full on keto, and my levels were never super high, maybe like 2 millimoles. And again, as an experiment, I wanted to see what happened if I would have a very obviously high fat cheat day, basically, of like, the keto legal foods that most people would say, like Quest bars, like just crap like that. Again, just to experiment. Wouldn't recommend it. And I was fascinated because when I tested just a carb source, even like a small amount, I think I had like some honey and like a pixie stick or something like that, and my blood glucose was like 145. And I was pretty surprised just because I'd never seen it personally that high, maybe even 150. But the day that I had like 6,000 calories of all these keto friendly foods, but the total carbs was actually like 300 grams, which you would think is like, there's no way you're still going to be in keto. Because I guess of all the fiber and fat, I was still at like 2 millimoles, and my glucose was under like 120. I mean, it was basically normal. So I just thought that was really interesting. I never made like a full video on that, but I was actually really shocked that I was still in ketosis with that many carbs and calories. But I guess I was in it for a long enough, like a number of weeks. And I don't know if you have any thoughts on that. I just thought it was interesting.
Yeah, I mean, technically you can't be in nutritional ketosis at, what did you say? How many grams of carbs? 200?
So like, I used like a tracker, and it was 300 grams of carbs, but a ton of that was these fibers that make these products keto,
Yeah, right.
friendly. So,
Right. Like the isomaltol glucose, I think it's called. Yeah. So technically, well, it's okay. So there's a lot of factors at play here. Well, number one, a lot of those carbs are not absorbed, but then metabolized by the bacteria in your gut and then
right.
converted to short chain fatty acids or sugar alcohols, which are about, depends on the sugar alcohol, but between like 2 to 3 calories per gram.
Right.
So that could be one thing that's playing a role here. The other is you probably were in ketosis for such a long period of time that your body has not did not switch over to any type of glucose metabolism. So that's one possibility as well. If you told me, Ralph, I ate 300 grams of carbs and I was still in nutritional ketosis, I would say you're lying.
Right.
But it happened to you. So it's very hard to explain. My bet is that you were young. You're probably already in nutritional ketosis. I don't know what your training was like around that time. Maybe you were exercising a lot and glycogen deplete.
I mean, that day I was off. I mean, I have very detailed, like I could pull up the Fit Day account of that day and I have like everything in Excel. Like I said, I was very surprised, but I just wondered if it was maybe so high fiber, so high fat. And again, I could find the numbers for you, but like 300 grams of carbs. I mean, how much of that was, again, sugar, alcohols, and all of these things that they count. So, but yeah, I agree. Normally, if somebody said they had that many carbs, and then who knows, maybe if I did that one more day, it would have completely been the opposite, or like, so it could have just been a transient thing.
Yeah, it's hard to stay in nutritional ketosis above 70 grams of carbs.
Yeah, I've been surprised by how much, and I think even Dr. Rhonda Patrick talked about this. Like most people who think they're doing these keto diets, they're often not. I mean, I've found that like if I even just try to keep my protein at 1 gram per pound, I'll do that for like a week or two, and I'll be at like 0.5 millimoles. Like I actually have to drop my protein quite a bit, really increase the fat. And then, or if I've done, like I have done a couple 3-day fasts, and then, I'll be in like, maybe 2 millimoles again. I've never had, some people have these levels of like 4 to 5. I've never had that. Even when I try to ketone salt, I have not tried a ketone ester, but the ketone salts like bumped it up like 0.3 or something. It wasn't very significant.
Yeah. So. Yeah. Most people cannot, like, again, it's keto has gotten so popularized that everybody's a keto expert. But it's very, very difficult to get into ketosis, nutritional ketosis, on a high protein diet.
Yep.
And I don't think that's a bad thing. I think that might be okay.
Right.
But you're not in nutritional ketosis. And that's just because we're using a lot of these amino acids for energy, and that's what the body wants to do. I could say it's harder to stay in nutritional ketosis on a higher carb diet, but it's not impossible on a high protein diet, although it will definitely throw you off if you do. I think it's best for people to find the nutritional plan that works best for them. I'm not an advocate of, everybody must do low carb, everybody must do keto, everybody must be vegan, like Mediterranean. It's what works for you, that's sustainable, that's also aligned with some of the data and literature. We know, like, if you are insulin resistant, you will have a very tough time convincing me that carbs are okay for you to eat at what's recommended by, the Academy of Nutrition or any type of large organization, the American Heart Association, right? Like, there's no way that 50% of your calories should be coming from carbohydrates if you're diabetic. It's just science.
Yeah. So I know we don't have a ton of time left. Last topic that is related. There was an article put out. I'll look at the date here. I'm sure you're quite familiar with it. So September 13th in the American Journal of Clinical Nutrition, the carbohydrate insulin model, a physiological perspective on the obesity pandemic. And a number of people sent that to me. And it's interesting because you have like the whole calories in versus calories out, and then you have the like insulin model of obesity. And it kind of seems like, I don't want to say that they're coming together, but at least the way, maybe it was misrepresented, but the way that I'd always seen it was like somebody like Gary Taubes, it really seemed like he was saying, like, you can gain fat in a deficit and it basically seemed like it was totally based on carbs. And a lot of other people said, like, no, it's calories in versus calories out. That's kind of the camp I've always come from. And then I heard Peter Attia say on a podcast, I don't know, 2 years ago, like, yes, we know that to lose weight, your calories have to be less than you burn, but we have to get into why, which I think if that's the stance, totally makes sense. This paper, it seems like the insulin model, they are even acknowledging that these types of foods cause an insulin response, cause increased appetite, cause increased calorie consumption, but they're, I believe, still acknowledging that these people are eating more than they're burning, which seems like maybe that's different than what they had previously said. I don't know specifically where you fall on this argument, but I'd just be interested to hear your thoughts.
Calories matter, but not as much as we think that they do. And that's me saying, I don't think somebody can lose weight if they're eating excessive calories, if they're already eating a healthy diet. So if somebody is at a homeostatic weight and they want, like, they're at their their normal weight and they want to lose more weight, they can manipulate that with macronutrient content, but the calorie intake will have a large influence on that at very high and very low levels. So one of the things to understand is how do macronutrients impact our hormonal levels, and specifically insulin. You cannot initiate, or in other words, insulin inhibits lipolysis. It's just as simple as that. Insulin, because it's in a fed state, will cause the body or cause fat cells to slow their metabolism or slow down lipolysis or beta oxidation and other biochemical pathways. That does not mean that if your insulin is high, you can't lose weight. So insulin matters, but always within the context of total calorie intake. So then somebody would say, well, what does it matter? If you got 50% of your calories from carbs, but you're still within your macronutrients, then you should be fine. Maybe if somebody's metabolism in terms of their muscle protein count, their muscle mass, and their thyroid function is adequate, if they're not insulin resistant. And most of the time, people underestimate how many calories they're actually eating. So if we can utilize hormones, which we've acknowledged, I think, as a scientific community, have an impact on the way that we metabolize fuel, epinephrine, adrenaline, cortisol, insulin, all of these things have an impact. It would be naive to say that it's only calories.
Yeah.
Because there are other things that impact how our fat cells work. Cortisol completely inhibits lipolysis. Insulin inhibits lipolysis. Even, in fact, cortisol induces lipogenesis. So it causes you to make more adipose cells. So it's hard for me to put my both feet in one camp. I have to acknowledge that there is science behind both of these things. But again, as we started, anybody who goes extremes in either way is probably wrong, because there's always something at play, whether it's at an intricate level, at an individual level, that makes the conversation questionable. I've had patients who eat the same amount of calories, but they've switched their macro content from high protein to high carb to high protein and low carb, and they lost weight. Is that because they eventually started losing more calories, eating more calories? Is that because they've tapped into fat stores that they weren't able to before? I don't know. I haven't done experiments on those people, but I can't disregard or ignore the fact that clinically we see this.
I guess what I would wonder, and what I would love to say or talk to Gary Tabbs about is like, I fully agree. Like if you have this thing on calories in versus calories out, there's just that simple equation. And the acknowledgement that absolutely activity, hormones can dramatically affect those numbers. I guess I would want to ask him, and I don't know your thoughts, but like, would you acknowledge that if net somebody is burning more than they are consuming, again, net, they will lose tissue weight. And if they are eating more than they are burning, net, they will gain tissue weight. And that's kind of what I would say, because again, I totally acknowledge, like, maybe if they had high cortisol, high insulin, it's a disaster and they're losing all muscle or something, they just can't let go of the fat. I just would go back to just like the thermodynamics of it, of like, at the end of the day, would they still acknowledge that the equation still holds true? And then you could get into, the hormones and how they affect all that.
Yeah, I think anybody who disagrees with, it's hard to disagree with physics.
Which is my point, right? Yeah. So right. I think a lot of the people talk over each other, and I think all of your points are super valid. I don't know, maybe people are just emotional because they're so vested in it, but.
Oh yeah. Nutrition is emotional, as emotional as politics, and emotional sometimes as religion.
Yep, for sure. All right, man. Well, again, thank you for taking the time. I know you're very busy, so it's great to have you on here. Where can people find more of your stuff?
Instagram at Dr. Ralph Esposito. My website, drralphesposito.com. Same thing on Twitter. All of my material and information is there.
Awesome.
Free to share.
We'll certainly have links. Thanks, Scott.
Thanks.